Welcome to my channel. We're gonna discuss advanced imaging techniques. Let's get on into it. So the first one we're going to talk about is sialography, and basically what it's used for is it's a method to see if there's any obstruction or inflammation within the ductal system of a major salivary gland. So you use this whenever you think that there's a mass or a lesion or tumor inflammatory process in the salivary gland. And so you would administer either a fat-soluble or a water-soluble agent as your contrast media, and basically the contrast media is going to be injected through retrograde iodination. Um, you're going to dilate and cannulate the duct with about half to 3/4 of a milliliter of contrast media. With a fat-soluble contrast media, this is a bigger concern because it has nowhere to dissipate off into, and it could potentially damage the duct if too much contrast media is placed in. So the advantages and disadvantages of the agents. For the fat soluble, as I said, one of the disadvantages is if you place too much fat soluble agent in the duct, you have a risk of a foreign body granuloma, and that's if the duct ruptures or the contrast media extravasates. The advantage is, of course, it's going to act as a better contrast agent because it stays within the duct and it's not going to be as easily diluted and by the saliva. So it's not going to transfer across glandular mucosa, and it highlights the ductal system very well. The water-soluble agent, on the other hand, you're not going to have the problem of foreign body granulomas because it can be dissolved or it can be broken down or dissolved into the saliva. So it has that big advantage. So you have no risk of giant cell carcinoma, giant cell reaction or foreign body granuloma. On the other hand, since it dilutes by the saliva, it means it's going to have a faster ability to break down that agent. So the contrast media is going to be available for a short period of time, and because of this, you're going to have poor visualization of the peripheral ducts. So this is basically outlining the phases of sialography. So you start with a ductal phase, then you have the acinar phase, and then finally it's the evacuation and post-evacuation phase. So the ductal phase is the initial phase of the injection of the contrast media into the duct. This is going to be relatively fast. And as you can see in the image on the bottom left, we have the agent that's been released into the duct itself, and it's showing the duct very well. After you wait about 5 minutes, at that point you're in the acinar phase, and now the contrast media has gone into the gland itself. So if we look at the second image right here, this is very indicative of a string of sausages. So if you look at where the arrows are pointing, you have these like little strings of sausages, or what looks to be like that. And this is called sialodochitis, and it's basically an inflammation or an abnormality. Now this third image is Sjogren's syndrome, and the image is very indicative because if you look at this, it looks like a fruit-laden branchless tree. Basically, it looks like a bunch of specks. So it's kind of like, in my mind, I look at it and I think of grapes, and there's like these random little grapes. And if you see a lot of random little grapes in one little spot, it's probably going to be Sjogren's syndrome associated with xerostomia. And then on the right here, what we see is this is a bilateral carotid swelling, and this is associated with somebody who's an alcoholic. The gland itself looks enlarged, and you have splaying of the ductal system. So these are just some abnormalities and some practical applications of sialography. So let's have a quick quiz question. So sialography is used to detect an anomaly of the salivary duct only, the salivary gland, the duct and the gland, or the gland tumors. I hope you pick C because that's the answer. So our next type of advanced imaging is computed tomography. So why do we use CT? It's basically used to diagnose malignant diseases. So it's great for staging primary lesions, assessing presence or absence of lymph node metastasis. Um, it can tell if the tumor has extended outside the bone or the degree of which there's extension within the bone. So this is very good if you're trying to see how much damage the tumor is causing. Um, Now, even though we're talking about it, CT being able to tell about the damage of the bone, this tumor is associated with the bone itself. So because CT is sending an ionizing ray, it's only going to be able to see the bone really well. So it's not going to see soft tissue, it's actually going to see the bone itself and the damage to the bone. So you can use CT when there's extensive lesions in the mandible or maxilla, especially if there's sinus involvement, if there's malignancy, osseous lesions affecting the TMJ, or if you want to assess the maxillofacial trauma. And you can also use it for sialography of salivary glands. Now, as I said, CT is ionizing. So there are ionizing rays that are going to narrowly be shot out of a tube, and they're going to go to the target site, and then the receptor is going to actually pick up on that. Another key thing is it's an axial plane cross-sectional image. CT is going to be 100 times more sensitive than a plain film. And with the newer units that are coming out, it can actually, the gantry has the ability to, with each revolution, has the ability to make smaller and smaller slices. So now you can get 0.5 millimeter to 1 millimeter or 2 millimeter slices. And what this means is the thinner the slice, the better the resolution, but the caveat to that is you have more radiation. So the features of CT is that you can do 3D reconstructions, meaning that you can do volumetric reconstructions, or you can make it look like it's a 3D image. It provides much more details. In terms of how it's measured, so Hounsfield is the unit that's associated with CT. So if something is greater density than water, it's going to be denoted as a positive value, such as a tumor or bone would be positive. If it's less dense than water, like fat, it's going to have a negative value, and of course, anything that's water-like, like a cyst, would be equal to 0. A scout image. So you can kind of think of this as a template, or if you're looking at a box that's for a puzzle. So on a puzzle box, you have the image that or the puzzle that you want to complete. But the puzzle pieces itself are each individual image that the CT is taking. So you have the snapshot of the full thing, and each puzzle piece is going to be your next image. So the scout image is that entire puzzle that's completed. I hope that made sense. So here are some things to kind of look out for, some abnormalities. So starting from the left, we have this kind of breakdown of bone, or your mandible. So you have a submandibular gland depression. Now if we look here on the second image, which is the top left, we see that there's this kind of breakdown where it's a very ovoid, unilocular, well-defined radiolucent lesion. This is a Staphny bone defect. It's a very common thing that comes up. Below that, we have a cemento-ossifying fibroma. So if we think about this, ossifying means bone. So we know it's within the bone. It's going to be involving the cementum, and it's a fibroma. Now if we look at the image in the third column, we have an odontogenic keratocyst. And if we compare it to the right side of that image, we can see that there's this mass that's actually growing into that sinus and creating that problem. And then on the far right, on the right-hand side of this image, we see that there is a high-grade osteosarcoma with fibroblastic component. And then below that is if we look right in this quadrant right here, we can see a metastatic thyroid carcinoma. So the next imaging technique is MRI, and this is basically used for diagnosis and treatment of soft tissue of the head and neck. Now, the other imaging techniques that we talked about have used ionizing radiation or ionizing rays. MRIs don't. You can think of it, if it's easier for you to think about it this way, when you took organic chemistry, an MRI is the same thing as NMR. It's basically the signal strength that it's receiving is based on the hydrogen content in the tissue. So you have two types of images. You have a T1 and a T2, and they're basically opposites. So the T1, it's going to be, whenever it sees fat, it's going to be bright, and that means it's going to be hyper intense. If it's cystic fluid, it's going to be dense or dark, and it's going to be hypo-intense. Exactly opposite is seen in T2 images. Of course, with MRI, it's a big magnet, kind of like an NMR. And so anything that's going to be ferromagnetic or able to contain a charge is going to basically be pulled by this MRI. So if a patient has a pacemaker or a article of jewelry that's ferromagnetic, it's going to pull it really, really fast. There are two types of MRI. There's the open and the closed MRI. The key thing about this is that the open MRI is going to have much lower resolution compared to a closed. So when we think about when to do an MRI, you really want to do it whenever you suspect there's an internal derangement of the TMJ, if the patient has salivary gland disease, if you want to assess any soft tissue invasion by a malignant disease, or if you want to evaluate intracranial extensions of inflammatory or neoplastic processes, if you want to assess perineural spread of malignancy, or if you want to assess or you have any suspect of brain tumors, and so forth. So the image that I show on the right is an example of a T1 weighted MRI, and this is a giant cell granuloma. You can kind of see the border of the granuloma on the left-hand side of this image. So nuclear medicine. This is probably one of the most sensitive forms of imaging. So if you want to image an organ or soft tissue, what you're going to do with this is you're going to administer an isotope, and a gamma camera is going to measure the radiation. Typically, static images are taken 30 minutes after the injection. The isotope that's used is technetium, mainly because it has a shorter half-life, so 12 to 24 hours. It's going to basically, technetium is going to be taken up at sites of inflammation or tumor. And this is because of increased metabolic activity or osteogenesis. So these are going to be seen as hotspots. The big takeaway from nuclear medicine is that it has really high sensitivity. But even if you look at these images to the right, you're going to see that it really has low specificity because it's just like blobs that you see of hotspots. But the advantage is that it has such a high sensitivity in the sense that at 5 to 15% demineralization, you're able to see versus an ionizing rays, which would be 50 or 60% before you can actually see or have any imaging that's apparent. So on the top, I'm showing a pleomorphic adenoma. On the bottom is a Werthin's tumor. So ultrasonography, it's very popular for pregnancies. Basically how it works is you have a sound wave that's directed at a target tissue. The sound wave is at 7 to 15 megahertz, and you basically want to use this for any sinusitis, extracranial carotid vasculature, salivary gland or thyroid masses. A big one that's becoming more advantageous in dentistry is cone beam CT. The advantage to cone beam CT is it has significantly less ionizing radiation compared to a medical CT. The way it works is it has multiple planar projections that are acquired by a rotating gantry to which the X-ray source and detector are fixed. The X-ray source and detector rotate around the subject. And basically it takes 150 to 600 sequential planar projection images, and basically a planar projection is the basis image, and when you have a set of them, that's called projection data. So now let's look at the difference between a medical CT and a CBCT. So CBCT, as the name says, it's a cone or pyramidal beam that's taking the initial image and then it puts them all together. The nice thing is it's taking one big image, so it's going around once, even though it's taking like 150 to 606 sequential images. It's one big one. Medical CT, on the other hand, it's a helical projection, which means that it's taking multiple axial cuts and it's doing multiple rotations through the area of interest. So if you compare the two, you can expect that there's going to be higher dose of radiation compared to a CBCT. Because there's going to be multiple rotations, you're going to have multiple detectors, and then it's also going to have unlimited. A medical CT is going to have unlimited scan volume, little scatter, it's going to have more detail for soft tissue. But of course, it's going to cost more and it's going to have a higher dose. While a CBCT is going to have a lower dose and a lower cost. It's only doing one revolution. It has a limitation to the scan volume that it uses. Unlike medical CT, of course, this is going to have a lot of scatter. It's hard tissue only. And so a CBCT, it's going to be an isotropic voxel, while a CT is going to be an anisotropic voxel, meaning not equal size. So you have three basic field of view, or four basic field of views. So your really small is going to be, if you want to look at individual T's, that's going to be a 5 by 5. You can go to 8 by 8, which is a slicing window, and this is still if you want to see a good region of interest. Both of these are going to be, as it sounds, dental alveolar imaging. Then you can go up to 4 to 6 inches. This is going to be basically from your maxillary sinus to your C2 vertebrae. And then your biggest is going to be for a trauma assessment, and this is going to be like if you want to do a lateral ceph, it's think huge. Of course, with any type of imaging, you can see image artifacts, and this is typically seen in a reconstruction. So some of them are going to be like beam hardening, and what that basically means is you have an increase in average energy of X-ray beam as the beam penetrates the tissue or dental material. So you have lower energy photons that are more easily absorbed, and this is going to show up as the arrow points. It's going to be an area that has cupping or streaking artifact. Now, metal streaking artifact, this is going to be a little more obvious. You're going to kind of see a very bright area, and that's just because the metallic object is going to absorb the photons, causing an incomplete profile. This makes it a lot harder for diagnosis. Then you can have ring artifacts, and this is basically caused by an uncalibrated detector element. Motion artifacts, of course, if a patient moves, you're going to see kind of that shifting or like the blurring at the spot where they move. So where I've circled off and have arrows, you can easily see that. So you have three basic views. You have your sagittal. It's if you were to cut a plane right from the nose straight to the back. And this is not just the nose, it's basically the front of the face to the back. So very straightforward. Then you can have the axial view. It's when you basically cut through the person from like as the image is showing, you're going basically like a horizontal cut across the person's face. And then a coronal cut is a vertical cut, but now you're going towards you're going from the front to the back, but you're using it basically cutting from the ear to ear. So here's some examples of things to look for. So if we look at the incisive canal, which is on the left-hand side, we see that it's kind of small. It should be within 6 millimeters. Anything above 6 millimeters probably means that you have some kind of tumor or growth. Your maxillary sinus is kind of straightforward. It's going to be the big space above your maxillary teeth. The maxillary sinus ostium is kind of that little hole where the arrows are pointing. Then you have your sphenoid sinus, and this is where the yellow circle is. And then you have your mandibular condyle. This top image is one of those tricky ones because if you look at it, you see your hyoid in the back, and then you see this kind of circle, and just kind of keep it in your mind. This is what the mandibular condyle is going to look like. The cornoid process. If you think about your anatomy, the cornoid process, right at the tip of it, it's going to be this kind of sharp point. So that top left image is going to kind of illustrate that. And the middle image kind of shows, if we're to look at it from the back of the patient's head, we'd see it like that. And then this bottom image is like from the side. Now, if we look at the styloid process, we know that it's going to be kind of a small point. So in this top image, we can see that it's easily a small point, and it's going to be more posterior to where the mandible is, or where the condyle and ramus is of the mandible. Now, if we have an ossified stylohyoid ligament, you could expect to see that it's kind of like this long styloid process because it's extending from the styloid to the hyoid. So it was at one point a ligament. The epiglottis, it's kind of straightforward if you think about it. If we look at the esophagus, and we're thinking about right at that point where the trachea and the esophagus kind of split, we think that there's like this little flap that sits there, and that's right where the esophagus, the epiglottis is. The genial tubercles and lingual foramen. The genial tubercles are basically going to sit right at the base of the lingual foramen, so we kind of see it bulging out in the top image. The foramen is in the middle image, and you can see the foramen in the bottom image as well. The hyoid bone is kind of interesting because anything that's a midline structure, the radiograph will show it as a double real image. So just keep in mind that the hyoid bone is going to show up as a double real image. Then we have the mandibular foramen. This is very crucial because the mandibular foramen is going to basically carry the IN, and it's also going to be the point where you can kind of know where you're going to do your block. So if we look at the mental foramen, this is also usually sitting by the second premolar. So if we look at the top left image, we can see that there's the second premolar, and right there is the mental foramen. The submandibular fossa is that kind of divot that leads into the most anterior aspect of the mandible. And it's going to be on the inside, so it's the curvature that you have on your mandible. So it's more on the inside of your mandible. The glossopharyngeal space, it's the space that's below. Like if we look at this opening, so we see our tongue is leading in. So where the tongue stops and the pharynx starts is where the glossopharyngeal space is. The nasopharyngeal space, as the name says, is going to be closer to the nose, and it's going to be where the nose and the pharynx kind of meet in that curvature right there. And then you have the posterior pharyngeal wall, and it's going to kind of show up on the left-hand side of the image, and it's basically the hole that's in the back. So a panoramic parallax is basically a pan. The disadvantage is that the X-ray source is from the back, which can lead to errors in estimation of anatomical location. It's not going to be a good representation of the anatomy because you can have superimposition, you can have a lot of issues with it. A better option is always going to be CBCT. CBCT is awesome because it's great for implant planning. It allows you to see the optimal size of the implant, the axis and orientation of the implant placement, and it gives you an ideal anatomical location for the implant. Some of the applications that said implant placement, ortho, endo, and perio. So for ortho, it's going to basically be used to show you where there are impacted teeth, if you have facial symmetry. It can also help in CAD-based therapeutics, so like if you want to do Invisalign. When you do rendering, it allows you to see any hard and transparent soft tissue. It's honestly awesome. And then you have endoperio, which it's going to show you abscesses, root fractures, internal, external, or combined root resorption. So basically, remember, CBCT is great for hard tissue. It can show some soft tissue. MRI is great for soft tissue. You got sialography, which is for glands. Yeah. So if we look at the TMJ, for instance, and we're looking at somebody who has rheumatoid arthritis, there are some key features to look for. So rheumatoid arthritis, of course, appears as a punched out lesions, sclerosis, osteophytes formation. And so if we look at this, we have this bird beak pattern on the right, where the right arrow is pointing. That's going to be your osteophyte formation. And directly in front of that, we see kind of a little patchiness, which is the punched out lesions. Other things to look for in a CBCT is you can see acute sinusitis, which is going to, if we look to the left of the patient's image, we see like these little bubbles. And this is going to basically show that it's acute sinusitis because it's these secretions that are showing. Chronic, on the other hand, comparing to the acute, is now we have these thick sclerotic cortical borders and the opacifications of the sinus, and that's basically showing chronic sinusitis. This image is showing the sphenoid sinus. And other pathologies, we can see that there's a right side carotid artery calcification. On the right side of this patient's mandible, we see that there is a odontoma. Sorry, I meant the maxilla. There is an odontoma. And then, same in this next image, we see a squamous cell carcinoma. This is going to appear almost as though the buccal plate is being thinned out and the entire lingual cortex is gone. So, thinking about radiation doses, going from least to greatest dose, your lateral ceph, which is mainly used for ortho, is going to be one of your least amount of dose. Then it's going to go from a PA ceph, pan, FMX, and this is an FMX that's F-speed rectangular collimation. And then lastly, a CBC with the highest dose. Another way to look at it is 4 bite wings is going to be less dose than a pan, less than an FMX, and CBCT is going to be your higher and CT is going to be the highest. So now, if we compare an FMX taken at F speed with a round cone versus a rectangular cone, the round cone is going to be a 5 times higher dose than a rectangular cone. Now, the speed of the film also plays a role. So if we have a D speed with a round cone, and we compare that to an F speed with a rectangular cone, it's an 11 times multiplier. The D speed with a round cone is going to be a much higher dose. So our dose itself depends on the machine, the volume, the detector types, the field of view, voxel size, and number of projections. Well, I hope this helped you out. If you have any questions, comments, leave them below. Please subscribe to my channel, and I'll be sure to make some more videos.